Welcome back. First of all, let me say how happy I am that a lot of you have messaged me and told me how much you like the videos. That makes me really happy, so keep those comments coming. Don't forget to share the videos, and thank you to all the people who've liked my YouTube channel and who have liked my Facebook page. That really means a lot. So today I want to talk about insulin. And we've already covered a lot of topics, but part of managing diabetes is with medications. And so you may be wondering why your provider decided to put you on insulin. A lot of factors play into that. So it would be hard for me to say for sure unless you were my patient. But a lot of times if the A1C is over 10, that's usually an indication that insulin is needed. There's a lot of other things that play into that as well. Usually what happens is that when you first develop diabetes, your body does a really good job of keeping up with the demand for insulin. Your pancreas just kind of compensates by making more insulin. But over time it gets to where the pancreas can't keep up with that anymore. And so this is when the blood sugars start to rise because the demand for insulin is way too much. The pancreas just can't keep up. And eventually over time the pancreas just kind of gets worn out and just kind of stops making insulin. And so a lot of times what we see is that when we start patients on insulin, after several days or a couple of weeks, their blood sugars dramatically improve. And part of the reason for that is that because we have been giving them insulin, we've given their pancreas a chance to rest, and so it has a chance to recover. It kicks in and starts doing its job again. So definitely, when you have a really high A1C, 11, 12, 13, 14, 15, is it possible for you to bring your A1C to goal without insulin? Maybe. We can't say for sure, but it'll be really hard. The best thing to do is to take insulin at least for a few months. Make sure that you're taking your medications, working on your diabetic diet, getting your blood sugars better controlled, and then try to transition back to pills. If you're a type 2 diabetic, of course. Type 1 diabetics always have to take insulin. So definitely the insulin or the medications that you're on are just as important as the diets that we talked about last time. Now, as far as different types of insulin go, there are, for our purposes, we're going to talk about 3 different types of insulin: long-acting insulin, short-acting insulin, and combination insulin. So whether or not you are on one type of insulin, more than one type of insulin, insulin and pills, that all depends on the situation. And what type of insulin you're on also depends a lot on the situation. Do we have a preference on insulin? No. We prefer whichever ones work the best for you and whichever ones you can afford. So if your insurance won't cover this brand, but they'll cover that brand, that's fine. We switch it to the one that's covered by insurance. If you have no insurance, we are going to switch you to something that is fairly inexpensive to buy without insurance. So let's start with the long-acting insulins. So long-acting insulins, this is anything like Levemir, Lantus, Basaglar, Tresiba, Toujeo, NPH. These are all long-acting insulins. They last anywhere from 12 to 40 hours, and they take care of the sugars that your own body makes. So that's why a lot of times it's given at bedtime. It helps your sugars, your fasting sugars, to be a little bit better the next day. You take these usually whether you're eating or not. If you're on a good dose, then hopefully you're not having hypoglycemia even when you're not eating. You shouldn't be. If you are, then that means we need to back off of your dose a little bit. The NPH has to be dosed twice a day because it only lasts 12 hours. The rest of them can pretty much be dosed once a day, but you will see them also being dosed twice a day sometimes. So either way is fine. The short-acting insulin, which is like Humalog, Novolog, regular insulin, these insulins take care of the sugars that your own body makes. So ideally, we're not treating your blood sugars when they're already high, like if you're on a sliding scale. If you're on a sliding scale, what happens if your blood sugar is 150 to 200, you get a certain amount of insulin, 200 to such, you get a certain amount of insulin, and so on and so forth, depending on what your sliding scale is. But what that does is it just treats your blood sugar when it's already high. Our goal is to prevent your blood sugar from getting high in the first place. So the long-acting insulin takes care of the sugar that your own body makes, and the short-acting insulin takes care of the sugar that's in your food. So ideally, you get the right amount of insulin with the right amount of carbs, and they cancel each other out, just like that. And then the next time you get the insulin and the carbs together, they cancel each other out. What happens if you take the insulin, the short-acting insulin, with no food? Your blood sugar drops. What happens if you eat without taking the short-acting insulin? Your blood sugar goes up. They really need to go hand in hand for it to work out and keep your blood sugars well controlled. What happens if you skip a meal that day? Then you skip that dose of short-acting insulin. And don't try to make up for the carbs by adding more carbs to your other meals, because then your blood sugar is really going to spike. So try to keep your carb intake consistent, keep your mealtime insulin consistent, and hopefully your blood sugars stay pretty well controlled. A lot of times it does take some adjustments from the initial dose of insulin. We start with one dose, and if the blood sugars are not at goal, we increase it. If the blood sugars are dropping too low, we decrease it, and that's how we get the blood sugars to be at goal. Then there are combination insulins. So these are going to be things like 70-30, 75-25, and basically that means that it has a combination of long-acting and short-acting insulin. So these can be a little bit tricky, because we don't want you to miss the long-acting insulin, because then your blood sugars are going to be high. But if you're not eating, we also don't want you to get too much of that short-acting insulin, because it's going to drop your blood sugars too low. So ideally, these types of insulins that are combination are given to patients who tend to have pretty consistent diets. That's the goal. If somebody needs to be on NPH and regular insulin because of the cost, but they don't have a consistent diet and they're not doing well on 70-30, then it's better to separate the insulin into long-acting and short-acting insulin and dose them separately. That way, if they're not eating, they still get the NPH, but the regular insulin can be held. As far as insulins go, whatever does the job is what we want you to be doing. And so it's really important that if there's an issue, if you can't afford your insulin, or if you're not able or willing to stick yourself as many times a day as what your providers want, that you let them know, because we'd rather switch you to something else that you are going to be able to adhere to better than nothing. Okay, so if you have any questions about insulin, go ahead and leave me a comment, and I'll try to get back to you and answer it to the best of my ability. Don't forget to subscribe to my YouTube channel. You can search my page on Facebook at A1C2Z. Like my Facebook page. Share my posts with your family and friends, anyone you know who's diabetic, nursing students, anybody that you think might benefit from the videos. Thank you very much. I appreciate all the support, and I hope that these videos will be very beneficial to all of my patients and any other diabetics who would benefit from them. Thank you, and have a good day.